All right, so on to cataracts. So cataracts is another eye disorder, right? You could argue it's refractory, like it's an offshoot of presbyopia where you have a lens problem, because this is all about the lens, right? It's not a cornea problem, it's a lens problem, right? So presbyopia is a lens problem, and this is a lens problem, right? And the problem here is not that we have a stiff lens like we have with presbyopia, we have a cloudy lens. We have a lens that has gotten dirty, right? Have you ever seen someone's phone? It's like, don't you clean your lens before you take a picture, right? So it has all kinds of junk on it. That's exactly what's going on with a cataract, right? The lens has all kinds of junk on it, and it could just because they're diabetic. And diabetes, they start hyalinizing things. They start making things crystallized, right? So diabetes is a significant risk factor for a patient with cataracts. Okay, so it's clouding of the eye's lens, right? The lens normally focuses things, and yeah, it's still operational, right? To a certain point, certain patients will be at high risk of it getting stiff, like diabetics also, right? But they are going to get, their lens might work, but it might be able to get fat and get thin, but there's stuff in the way. So it's going to be a cloudy image, right? And has a really cool Instagram filter. I try to look it up. I forget what it's called. Where everything turns sepia, right? Everything turns brown tones, right? We get that antiquated look from the 70s. Okay. So if light can't get through, sometimes it won't reach the retina, right? It'll get blocked at this little debris right here, and that will be that won't be out of focus, but also you won't be able to see that piece, right? So the clarity of the lens is the clarity of the image. You have poor contrast. Things are fuzzy, right? So it's like it's out of focus at all times, but it's not out of focus because you can't bring the image into focus. It's because there's something on your lens, right? You got some greasy fingers after you just ate some, whatever we ate over here, that's greasy and hot, right? That's going to then get on your lens, and then now it is blurry, right? So blurry sepia tones are common with cataracts, okay? The lens is composed mostly of water and proteins. What protein? Collagen. So people with steroid use are going to start breaking down the collagen, and your body's like, whenever it breaks something down and it tries to rebuild it, it's like, I know exactly how that looked beforehand. No problem. Say no more, right? And it does not look anything like it. Like they paid this art restorationist to redo Jesus, and he said, I know exactly what Jesus looks like. Say no more. This really happened. So the guy walked away with a whole bunch of money. So that's repair, right? So that happens with the lens. Like I know exactly what a lens looks like. It'll look super clear. You won't even, you'll be able to tell all your friends about me. And it's like, no, that's not right at all. So the same thing happens with CHF, right? When you have CHF, your heart remodels itself. So I know what a heart looks like. It's like, no, you don't. Just stop. I'm gonna give you a beta blocker, so we stop that rebuilding. Or give you an ACE inhibitor to stop that rebuilding of the heart, right? Same thing with bones, right? We talk about bones. You try to rebuild it, and it's imperfect. Okay, that's what happens with PDB, right? So anyways, so risk factors, age being the most common, right? Old age can put you at risk for cataracts. Diabetes will accelerate that pathway. Steroids will also accelerate that, right? Inflammation will do it as well. So obesity and such puts you at risk. Smoking, alcohol use, that all puts you at risk for cataract development, right? If they have damage from surgery, a Russian surgeon who goes a little bit too far and cuts into your lens, that's going to cause some problems as well. Trauma, just being out in the wild, and you get trauma to your eyeball, you can get trauma to your lens, and then you can get cataracts, right? So cataracts, they reflect back the light. That's not supposed to happen, right? Your retina will reflect back light. Like if you shine a ophthalmoscope into someone's eye, there's actually something called a red reflex, what cats have, right? You can see the back of their retina, and it shines back at you, right? But your lens should not shine light back at you. That's a sign. That's a cataract. Okay. So UV light exposure is also a unique finding that could put you at risk, right? If you go out to eclipses and they tell you not to look at the sun, and what do? Take off your sunglasses, look at the sun. Not only is it going to damage your retina, but it can also chronically cause a risk for cataracts, right? So those that are outdoor workers, those that do landscaping, those that do sports, and they smother this black tar on their eyeballs that doesn't work to try to reflect the light, that could put you at risk for cataracts, right? So cataract formation, right? You have decreased contrast, so things are blurry, right? Well, what's the difference between blurry and contrast? The things are not sharp. The images are not nice, right? So instead of being a nice line like this, it looks somewhat like this, right? I'll just do red again, right? So it's out of focus, right? Instead of being a sharp, crystal clear image, right? And also it'll be in sepia tones, right? All right, so cataract symptoms. So they can be out of focus, and it'll be sepia toned, right? So you see this lens down here has become sepia, right? So the image goes from nice, clear, crystal clear image to a sepia tone, but also it is out of focus, right? Also, certain parts of the image might get occluded, right? So you can see how this is not sharp, right? It's in focus, but the contrast is poor, all right? So here's some of the advanced cataracts in the top right, and they can't see the start of a step or the end of a step. So that puts them at risk for what? For falls, right? So they have dim vision, so these guys should also not be driving at night, right? That's going to cause they can't see clarity, but also their vision is dim, all right? So imagine this is like perfect during the daytime at 12 noon. What does it look like at night? Not great, okay? So you got the fading yellowing of colors, right? They got glare, right? Not so much like the ghosting, but glare, right? And they got a halo around lights, right? Are you an angel, or is that just a symptom of my cataracts? All right. So teaching, how do you teach someone to manage this or prevent this? Well, they got to manage their diabetes, obesity, and smoking, and all the other fun stuff. But they should get yearly eye exams over age 40, especially if they're higher risk, so we can then identify it early and even replace the cataracts if we need to. Because what if you just let the cataracts just go forever? Well, your body's always on a use it or lose it system, right? So if you don't use it, it's going to go away. So you'll start getting blind over time. So you can see all this light goes into the cataracts. It gets refracted in different ways because it's not pure. There's a lot of impurities in it. So the light gets blasted everywhere. It's in focus, but it's blasted everywhere. So it's blurred, poor contrast, sepia tones. And eventually, if you don't use this retina, it's just going to say, you know what, I have a better use for this energy, for these proteins, for these things. I'm going to use it elsewhere. We're not going to try to repair what's going on there or maintain your retina. Okay, wearing sunglasses. Why should they wear sunglasses? Because what puts you at risk for cataracts? Some UV light, right? Lose weight, stop smoking. You have 2 times the risk for cataracts if you smoke 1 pack per day. All right, and please teach them to Uber. Okay, what else do I have in here? So that's the idea behind cataracts and their symptoms. So that was on purpose, but I don't know how long I put the animation for. Too long. All right, so the treatment for cataracts. How do you treat someone's eyes that have a lens that is too cloudy, right? Well, just like any surgeon, we're going to take it out, all right? You can just take it out and hope for the best, but usually we replace it with a nice other lens, right? Otherwise, your ciliary muscles and such don't work great, right? So we replace it with a brand new clear prosthetic lens, right? So those of you guys that rub your eyes, right, you're just go right at it, right? Rub your eyes nice and get those eyeballs going. But after cataract surgery, please don't rub your eyes like that. Otherwise, your lens won't take. It will displace the lens. It will subluxate the lens, right? It will make it so it doesn't work good, right? So we'll talk about post-op care shortly. But we do cataract removal surgery, right? That's to take the cataract out. And we can do it 2 ways. We just make a huge freaking incision and just pop it out. Or you can go, what's a good word? You just go Jamba Juice it, and you just go in there and you just crush it up, right? And you suck it out, right? And then replace it with a little lens. Okay, so that's the most common reason. Most common way nowadays, the phacoemulsification, where they emulsify it. They literally blend it up and then suck it out, right? And they always put a lens back in what they took out. So here's an example of cataract surgery, I think. Hold on. That does not play. Maybe I have to click the next slide. I don't know. All right, I'll play that video shortly, but that's the cataract surgery video. All right, so complication of cataract surgery is you can detach the retina. So that's coming up as a complication of cataract surgery, but also retinal detachment can happen just because, right? Just because they have a trauma, for instance. or they have like a genetic situation where they're high risk for their retina detaching. So we'll talk about that next, but that's where your retina literally detaches because of cataract surgery. You emulsify, you put too much vacuum pressure, and you suck up some of the back of the retina. Okay, so cataract surgery improves about 95% of someone's vision and prevents blindness, right? Remember, on a use it or lose it system. All right, so intracapsular cataract extraction, that's just where you just take the whole thing out and put a replacement in. That's usually been replaced by this phacoemulsification. All right, so what's the post-op care? What do you do afterwards? All right, so post-op care is no rubbing, right? Don't rub your eyes, right? Don't put much pressure on it. We have these little special goggles that we can wear, all right? Protect your eyes against injury after surgery. No sneezing, no bending, no vomiting, no lifting greater than 5 pounds. We're not putting any strain on our orbits or our eyes, any kind of increased pressure on our eyes. Because if you lean over, you can feel the pressure in not only your head, but also in your eyeballs, right?
How do you prevent someone from sneezing?
Stop. You scare them? I don't know. Right? So you avoid sneezing if possible, right? So guafenicin is for coughing. That might help with sneezing too. All right? Reduce their pepper consumption. What's that?
Sneeze with their mouth open so they don't put as much pressure on
Sure,
them.
you can sneeze with the mouth open. It's gonna look really weird, but anyways, no constipation, no straining in that way. Fluid fiber, stool softeners, all right? No eye straining. There's a 20-20-20 rule, which we did not observe this weekend. That's cool. All right, that's where after 20 minutes, for 20 seconds, you look at something 20 feet away. So that's the 20-20-20 rule. Every 20 minutes, you want to relax your eyes. Head to bed greater than 30 degrees. Yes, right? It's the right thing. It's the right answer. All right, they use the eye shield, which we talked about. And then wipe excess tears of tissue. Don't do this again, right? We're not going to be rubbing their eyes. Get the tears out, right? We make sure they give eye drops correctly, right? If they're using like saline to prevent dryness, or there's other this is the kind of post-op eye care in general. If they need antibiotic ointment or they have glaucoma or something, we're going to make sure we're giving eye drops correctly. So you learn this in fundamentals, but how do you properly give eye drops? Where does it go? Does it go like this, right on the pupil? No, you have to create a pocket. You have to create an invagination that you can then drop the eye drops into. Okay? Yeah, pull it down, and then where do you put it? You put it in the middle, and then you put a little pressure right there for where? Which one? 1 or 2? The one that's circled. It's like, where's their nose at? Anyways, it's at the inner canthus. You find it, and then you apply pressure for about 10 seconds or so, right? All right, so then what else? You notify MD if there's any vision changes. They just replaced their cataracts. There shouldn't be vision changes. If there's vision changes, it might be some retinal detachment. Okay? Any eye discharge, that means it's a post-operative what? Infection of some sort. Okay? So here's our inner canthus right there. And then eye surgery is the stuff of nightmares.
Did they knock you out during this?
Negative. All right, so I don't know why the video didn't play, but that's for your enjoyment later. All right, so retinal detachment, that is where your retina has detached from where it's supposed to be, at the back of the eyeball, right? So you can see right here, the retina has detached, right? So because it detaches, it now creates a conduit for fluid to get into it, and that fluid's going to detach it more, ironically. So it's an emergency. We have to fix it right away, because who cares if the retina detaches? Well, look at all those rods and cones that are on the back of the retina, right? So you're going to start losing your vision. It's really hard to replace a hematoma and to reconnect those rods and cones. You got to hope for the best. So we got to try to fix it as best as possible. So it's this back layer and the layer right above it that separates, right? So the retinal pigment epithelium, that's with the back layer that all these things are glued to. And then, of course, we can get a rip if it's from surgery or from trauma. And then, ironically, fluid will make its way back in there, and it will start separating it more, which is the danger here. Okay? It can cause permanent vision loss. It's a what? It's a medical emergency, right? So it could be extreme myopia. It could be injury, cataract surgery, like I mentioned. History of retinal detachment puts you at high risk for happening again. Systemic diseases can put you at risk as well. The most common is where we have this tear and the fluid, the vitreous, the humor gets into and separates the retina even further. Okay, And actually, it said the aqueous humor. I don't know why you didn't correct me. But the vitreous humor is like the jelly, and the aqueous humor is literally like liquid. It's like thin liquid, right? It's like synovial fluid almost. And the vitreous humor is what kind of it stops like right here. It's a whole big compartment of like 2/3 of vitreous humor, just thick. But it's the aqueous humor. The reason I bring it up is because it becomes a problem with patients that have glaucoma. How you for glaucoma. Okay. So that's the idea. With the aqueous humor is we want to slow down that production in with glaucoma. Here it just becomes a nuisance and it starts separating that layer further. Okay. Tractional, it's like with a scar tissue, puts you at risk for a further retinal detachment. Exudative means an infectious process has gotten hold, right? And that's causing a separation, an imperfect healing process. And then we got this growth, like almost like an abscess inside the eyeball, separating the retina. Okay? So signs and symptoms, it's gradual, right? Or it could be sudden. Sudden onset is what we're concerned of when they have sudden vision changes, right? Especially after a trauma of some sort, right? They get flashes of light as their retina is being torn off the back of its membrane, okay? It's curtains, literally, over the visual field. So it just all just becomes black and blind all of a sudden, right? It's painless, doesn't hurt unless they had trauma, right? And it can be like looking through cobwebs and not like maybe some floaters, but really all these cobwebs are in the way and everything gets super hazy and then the vision just becomes curtains. So here's a example of that. All right, maybe I have to connect it again to use my mouse. I'm not sure what's going on, why I can't play videos. Let's see my arrow now. Now I have an arrow. So an example of retinal detachment here. Although it doesn't want to click it. That's weird. Sorry for the technical difficulties. Anyways, that is retinal detachment also. So I'm going to figure out why the videos aren't working. Maybe this one will work. All right, so cataract surgery is super easy to perform. And hopefully you don't get retinal detachment, but that is one of our complications. And this is how you fix retinal detachment. So where's my cursor now? So retinal detachment, you can use lasers. That works. All right. So lasers is one thing you can do. You can scar the tissue and stop it from detaching further. So we just put lasers over here, right? And we start scarring the tissue so it stops separating, right? So lasers will be an option. And we have different options for lasers. Basically, we're creating a scar tissue. We can use the lasers, or we can use what's it called over here? So pan-retinal photocoagulation. Use a light rays to freeze and cause, again, scar tissue so that it stops the separation of that retinal membrane. Okay. And then we have pneumatic retinopexy. So pneumatic being like air, right? So a pneumothorax or pneumobilium or something like that. So we got a pneumatic retinopexy. So we're going to repair the retina with air, right? And again, that's if tears up here at the top of the eyeball, we're going to put an air bubble in there, and the air bubble itself is going to be enough pressure to tamponade the eyeball so it doesn't separate further. right? So that's the idea behind this, this bubble, right? So the ophthalmologist literally passes gas, and then they put the bubble into the eyeball, and that gas will expand over the next couple of days, and that will then hopefully keep the eyeball tamponaded, the retina tamponaded, so it doesn't separate further, right? And then you have to instill the biggest amount of fear in them altogether. You have to say, well, you cannot lie supine. Otherwise, the bubble will go to the front of the eye, right? And you probably won't be able to see good, but also your retina will further detach. So they always have to lay like this. They have to buy this on Amazon and wait 2 days. They didn't buy Prime, and they have to make sure they are sleeping prone. Because if you're sleeping prone, the bubble's gonna go to the top, right? Air rises, right? So they have that option to as for repairing their retina. Yes.
4 to 8 weeks you have to do that, or how much?
Upright or sideways for 48 hours to maintain it. Yeah. Okay. All right, so gas ball will reabsorb over 4 to 8 weeks. So it's not like you have to go back to the ophthalmologist and get it taken out. Okay, but it can prevent aqueous humor drainage, and we talk about glaucoma with aqueous humor. We don't want aqueous humor to build up, and aqueous humor gets reabsorbed at the front of the eye. So if the bubble gets to the front of the eye, it can stop that, and then we get to this buildup of intraocular pressure. All right. What they do nowadays, they put a scleral buckle, right, a little buckle over the eye, and they have to work around all 6 extraocular eye muscles, and they have to put that buckle behind it and wrap it around, and they kind of got to squeeze the eyeball shut, and that's going to also provide some external tamponading. Okay. Obviously, that's going to increase the pressure in the eyeball too. Another option is vitrectomy. Right. So vitrectomy is, again, we're ectomine. We're putting a cut into the vitreous humor, right? The vitreous humor is the back 2/3 of the eyeball, and we're going to go in there and we're going to try to repair it as much as possible and suck out all the extra fragments. Okay, so that's the idea behind a vitrectomy. All right, they just slurp it up. Okay, so that's how you repair a retinal detachment.